Okay. Oh, wait. There's no music. There we go. Hello, good evening, everybody. Hello, hello. Let's see. Esophagus, yes. Hello, HD Wink. Hello, Abdul. Hello, Pokarip. Archetype, hello. Hables, hello. Nimby the Deadly Nadder. Hello. World, hello, hello. Frotter, hello. Welcome to the stream. Hello, hello. Oh my god, I'm still coughing. Good morning, Dr. Shiori. Long time no see. Hello, good morning to you, and good evening to everyone else living where I am. Congrats again on being a YouTube partner. Oh yeah, that's right. This is my first stream in YouTube after achieving YouTube partner, but I will be holding a monetization celebration stream sometime next week. So yeah, super chats and stuff are still off right now. I'll be turning them on next week when we have the celebration stream. I actually don't know what to do for the celebration stream, but I'll think of something. Kakaroon tayo ng pakulo. Yeah, YouTube partner. After 5 years. Better be say-so after monetization. I am say-so. I've always been say-so. What are you talking about? Hi, Doc. I want to ask, can heartburn because of hyperacidity also affect the actual heart? No, it doesn't, and I will show you why. Okay, guys. Karaoke, Is it safe to do karaoke streams on YouTube? That's the thing. Is it safe to do karaoke streams on YouTube? Because, I think copyright stuff is a thing in YouTube. That's the problem. That is the problem with karaoke streams. That's why I do karaoke streams on Twitch. Yeah, I know people who do karaoke streams on YouTube, they have it unarchived, so I don't know if... Yeah, I'm gonna end up nuking the VOD, which I don't want. If I'm gonna do karaoke, it'll stay on Twitch. We'll see. I'll think of something. Don't worry. I'll come up with something. Anyway, guys. So, forgive me. I still have cough. I still have some cough. It's like it's better than before, but I still have this slight irritation in my throat, a post-nasal drip that is cough, that is triggering my cough. So yeah. So tonight, we're gonna talk about esophagus and stomach. I know I did a medical education stream before on stomach, like 3 or 4 years ago. So, a chunk of this PowerPoint is just gonna be from the old one. I just added esophagus stuff, and also, to be honest, this is gonna be a bit scuffed because I didn't finish editing the PowerPoint. I haven't finished editing the PowerPoint. I'm so sorry. I just added some bits of esophagus, and then I was going to put a portion of esophageal cancer, but then I'm out of time. So this is gonna be scuffed, and I'm gonna need, okay, I need this. I'm gonna need some código on here. Esophagus is an organ that I haven't seen, I haven't done surgeries on esophagus much. Even during my residency. It's so rare. It's not, esophageal stuff isn't rare like as a condition, but I mean, like, we don't see it often in the hospital. Or usually it's non-surgical. It's non-surgical. That's why I will try my best to cover what I can in esophagus. I'll try to. And besides, I need to know I need to do this also because I am studying for an exam. I'm studying for an exam, so. And this is one of the topics I had to read on. Hold on, I'm just fixing the cord. God, wait. Okay. Your throat getting... Hey, the throat is actually different. Anyway, okay. So, why did I decide to do esophagus and stomach? Aside from that, I need to study it. Actually, okay, I'm gonna show you guys why. There was a certain rigor on Twitter. Wait. There was a certain rigor on Twitter that released an asset like sometime earlier this month, like in the first week of April. The rigor is Kevin. I don't know. Maybe some of you are familiar. He releases weird assets every now and then. Most of the time, the assets are very yabai. But he rigs V-Shoujo models, so I think we know who you're talking about. Yeah, it's Kevin. Just said his name. It's Kevin. I'm gonna play it. I'm gonna show you guys, okay? Where is it? Oh, wait, what? Where is... Oh, oops. Okay, here it is. Wait, why is it so... Okay. I'll try to make this large, and I'll try enlarging it, okay? So, yeah, it's this. It's this. I'm gonna play it, okay? I think it's safe anyway. So, look at this. I know it was supposed to be some kind of vor kind of video or something. But when I saw this, I was like, what am I looking at? And then I saw this, yeah? The first thing that came into my mind is like, holy crap, this lady, his VTuber has a achalasia and gastroparesis. I actually quote-retweeted this. So when I saw this, I'm like, yeah, I think I should talk about this because we're gonna talk about anatomy and esophageal and stomach diseases. It's so weird. It is so weird, yeah. And here goes the vor. Yeah? Okay. Alright, okay. So let me pause. Let me take that out. Okay, so just to show you. What did I just get entered to? Yeah, you just entered something cursed. Cursed, but educational. Okay. It's trying to awaken some... Bokari, behave. Bokari, behave. Okay. Alright, let's go. Let's go. Okay, let's start with the esophagus since that's the first organ. I mean, before you get to the stomach, you're gonna pass by the esophagus, yeah? Okay, let's go. So, here we go. So imagine this is the body. Or well, actually it is the body. Don't imagine this. Imagine it to be your body. So we have this whole thing. It's called the upper gastrointestinal tract. So it starts from the mouth. Your digestive system starts from the mouth all the way up to your anus. But we're gonna talk about the upper GI. Or the upper gastrointestinal tract. So that's mouth, esophagus, stomach, duodenum. But we're gonna stop at stomach. Okay? So... Okay, chat. Tell me, describe to me, guys. Describe to me, chat, how you guys eat. How do you eat? As a human being, how do you eat? Describe eating. Describe eating, chat. Describe eating. What is the first step to eating? What is the first step to eating, and what do you do when you're eating? I photosynthesize. What are you, a plant? Chew, swallow, urine. Chew my food, swallow, chewing. Okay. Okay. You guys eat. Chew, swallow, intestine, melting, poopy. Mewing. Wait, why are you mewing? Wait, why are you mewing while eating? Okay. So anyway, okay, yeah, you chew. Okay, so when you eat, you put food in your mouth, right? You're gonna chew it, and then after you chew it, you're gonna swallow. Yeah. So chewing is part of digestion, actually. Chewing. As soon as food enters your mouth and you start chewing, you're already digesting the food because of your saliva. So the mouth has a big part of digestion because you can't swallow food whole. You have to chew it down, or else you're gonna choke. You see this area? Do you see this area? This is here on the neck. So this is your tongue. See this large muscle right here is the tongue. Okay? You eat your food, you're gonna salivate, you're gonna chew it, and then you're gonna swallow. When you swallow, your epiglottis is gonna close the opening to your trachea. Okay, this is the trachea. You can feel, if you watched my thyroid, is it thyroid stream? My previous streams about the thyroid or the neck, or my BLS streams, I told you about the trachea, right? You just feel the middle of your neck. You're gonna feel something firm or hard in the middle of your neck. That's your trachea. You can feel your Adam's apple on top of it. That would be the the cartilage. And below that is the trachea. Okay, so that's this. That is where the air passes through when you breathe. So when you swallow, the epiglottis is gonna cover this opening. Because look, your trachea, your airway, and your esophagus are pretty much connected. And the epiglottis has to cover this up so that food doesn't accidentally go to your trachea. Okay? So when you swallow, the food will go from your mouth down here into this small tubular structure, which is the esophagus. Okay? It's gonna go down here, wee, and then to your stomach. Okay, that's where the food path goes. The path of the food. Okay. Alright. Oh, okay, wait. Also, if you notice in the anatomy, the stomach is a little to the left, or majority of the stomach is on the left, okay? The stomach, I'll get into the anatomy of the stomach later on, but if you look at this image, the stomach is more to the left than in the middle and the right. So if we go back to the if we're gonna be a little nitpicky, if we go back here, what happened? Where's my... Oh, there we go. If we go back here... where's that photo? You can already see that the anatomy here is wrong. His anatomy's wrong, and I think his tweet checks out. The stomach's more on the left side, okay? I like how the windpipe is a bit larger. It is, actually. It's larger because it has to be open. It has to be open. Like, it should not close. That's why it appears larger. It's supported by rings. Okay, our trachea is made out of rings, so it has to be wide open or else you can't breathe. Okay? Doc, yung parotid gland nasa oropharynx po ba? No, it's not in the oropharynx. It's outside. Your cough needs attention. I'm already on meds, don't worry about it. It's anatomically correct by horny You know, come to think of it, people who do... You know, every time I see... art or anything like this where they try to be horny or something, you know, like if you saw my Facebook, I shared something. I shared something on Facebook and it was just anatomically wrong. Yeah, you know, when you know anatomy, all these things are funny to you. Once you know anatomy, it just all these things look ridiculous to you. And I will do an anatomy stream one of these days. Okay, I'm gonna do an anatomy stream. Because once you know your anatomy, all these things that you see that artists, or if they don't know their anatomy, if artists don't know their anatomy, or if stuff like this, if, you know, they make stuff like this and they're not sure about their anatomy, it's gonna look funny to you. So anyway, yeah. So, wait, hide this. There we go. Most of the cultured work these days are mostly anatomically incorrect. Well, to be fair, these people, when artists study anatomy, they usually go for like musculature, joints, and all that, I think. They don't really do internal organs. At least, I don't know. Maybe some do. I don't know. Alright, so next. Now, do we have any med students or someone in surgery or medicine? Because this next slide is important. I'm gonna try to simplify it for those who are not in the medical field. Okay? This is a lot of words and a lot of numbers. But as a surgeon, and probably as a gastroenterologist for other doctors, you gotta know this. This is a very important anatomy. Yes, the constrictions. So there are 3 parts to the esophagus. Okay? Because you saw a while ago. The 3 parts is just divided into like cervical, which is the neck, thoracic, and abdominal. So cervical, thoracic, and abdominal. Cervical is the neck, thoracic's chest, abdominal's in the abdomen. The cervical esophagus is 5 centimeters long. Like, we have to know this. And then the thoracic esophagus is 20 centimeters. And the abdominal esophagus is short. It's just 2 to 5, because it enters into the it connects to the stomach. Okay. This is important to you, medical peeps there. All right. And yeah, approximate that length. Yeah, we have to know this. So the longest part of the esophagus is the thoracic esophagus, which is in the chest. We also have to know how long or how far it is from the incisor teeth to whichever part. Okay? That's why, if you are a nurse or a doctor in clinicals, they're going to teach you how to insert an NGT, or a nasogastric tube. That is the tube that goes into your nose, and it goes straight into the stomach, right? You have to know you have to measure that. Before you insert the tube, you have to know how long you're gonna put it inside. So from here, probably not incisor, you're gonna start at the nose, right? But it's almost like slight difference. You have to measure it from here until the stomach. So the whole esophagus is gonna be like 40 centimeters, but you have to go a little longer to enter the stomach. So more or less like 50 to 55 should be in the tip should be in the stomach by then. Okay. Is this related to intubation? No, intubation is different. Intubation, the tube goes in here. The trachea, not the esophagus. Intubation is for breathing. Nasogastric tube is for decompression or for feeding. Ventilator tube goes into the trachea. So mouth into the trachea. That's how they measure the NGT. Yeah. What they do is they place the tube, the NGT tube, measure it from your nose and the tip. The tip has to be at the epigastric area or the middle of the stomach. Around here. They measure it until here. They place the tip on your stomach here. And then measure it like that and curve it into your nose, and that's how they get how long it's supposed to be. But the tube itself has like a measurement, and if you just want to be quick about it, out of all the patients, on average, every patient I've had an NGT tube inserted on, the marker I use is 55. So 55 centimeters. That is my sweet spot. That is my marker. Like, put it at 55 cm. That's gonna be in the stomach, and then just adjust it from there. If it's not like, if nothing is like, you can't take any stomach contents from that 55. You just have to adjust it, pull or push. Okay. And then another important thing for the doctors there, or the medical peeps, especially surgeons, we gotta know these three. Or no, not three, it's four. Oh no, three constrictions of the esophagus. So you have one here, the cricopharyngeal constriction at the level of C6. When you say C6, it means the cervical spinal bone. The 6th cervical spinal bone. So yeah, that's how we know. That's why anatomy is important to us. We gotta know these things. This means that there's a constriction. Like, the esophagus is a tube, but there are certain points where it gets narrow. So this is one. The cricopharyngeal constriction, because of the muscle in the throat. Okay? It narrows this. The second constriction is the bronchoaortic constriction at the level of T4, or thoracic spinal bone, or thoracic vertebrae 4. At the level of that. So the esophagus is narrowed because of the aorta, basically. It's because of the aorta. You have your aorta arches over the heart, and it causes a narrowing on the esophagus. Okay? And then your third constriction is the diaphragmatic constriction. It's caused by your diaphragm. Okay, the diaphragm is a muscle of respiration. This is the muscle that you use for breathing, and it is also the muscle that separates your chest, or your thorax, your thoracic cage, or your thorax from the abdomen. So that would be this line here. There is a hole in the diaphragm where the esophagus and the aorta and the vena cava passes through. Okay? And there's a bit of a constriction here, of course. So that's why there's a narrowing there. Okay? So, those are important for the medical peeps there. If you're in med school, and your professor asks you, okay, what are the 3 constrictions? Oh, just say, oh, this is it, C6, T4, T11. Cricopharyngeal, bronchaortic, and diaphragmatic. You're good. You're gonna be... Mabango ka na. Mabango ka na. Also, if you want to know how long, what vertebra the esophagus covers, it's here. C6 to T1 or 2 for the cervical, T1 or 2 to T10, T11. Thoracic, abdominal, T11 to T12. T10, T11 to T12. Okay? Mabuti tatatandaan mo lahat yan. Of course, man. Medicine is no joke. You're in med school for 4 years. You take senior internship for a year. You take your licensure exam. And then, if you're a surgeon, that's some extra years too. You have to remember this. As a doctor, if you're gonna take up medicine, if you're gonna be a doctor, you have to know this. There's no escape. There's no escape. You have to know these things. No matter how much you hate it. Here we go. Another anatomy image. So, parts of the esophagus. Aside from the constrictions, okay? Important parts of the esophagus are the sphincters, okay? These are the muscles or the areas of the esophagus that prevent reflux, okay? So you have the upper esophageal sphincter, or the UES, and you have the lower esophageal sphincter, or the LES. The LES is the one that's more important here in the when we talk about disorders of the esophagus. EGJ is the esophageal gastric junction, so it's basically the connection or the area where the esophagus becomes the stomach. Okay? So these sphincters are important in swallowing. When swallowing, okay? They are very important when you do the swallow and when you swallow. Alright, next. Oh, okay, guys. Okay, chat. Okay, chat. What is the purpose of the esophagus? What do you guys know about the esophagus? What does it do? What is its purpose in your body? What is the purpose of the esophagus, chat? So sphincter's not the bunghole. What do you mean the bunghole? Okay, transport, tube, to deliver food in the stomach. Yeah, okay. Plumbing. Plumbing? Bruh. Okay. Yeah, transport. Purpose of the esophagus: transport, swallowing, and protection against reflux. Okay? So yeah, it's very simple. I mean, it's a tube connecting from your mouth to the stomach. It's transport, mainly transport, but it has other roles, especially protecting against reflux. This is where the sphincters come in. It's kind of like the anal sphincter, you know, the sphincter of your butt prevents you from having incontinence, right? If you have a patent sphincter, if your anal sphincter is good, then you shouldn't be shitting your pants right now. Yeah? You're able to control your shitting. You're able to control your pooping because of your sphincter. Okay? The difference is, anal sphincter you can manually or voluntarily control. For the esophagus, it's more like it's more involuntary. Okay, it's involuntary because it's a smooth muscle. Though your anus is made out, it has the smooth and the skeletal muscles, and skeletal muscles are voluntary. Okay, so while your anal sphincter prevents you from shitting yourself, your esophagus or your esophageal sphincters are supposed to prevent you from regurgitating or vomiting. Okay? Now, someone in chat mentioned the term peristalsis. Wait. You know what? Let me get my... I'm gonna start writing down on my slides. Peristalsis is a very important term. Okay, where's my pen? This here. Okay. Can I choose a color? Let's make it blue. Someone in chat mentioned, oh shoot, wait, hold on. Why is it? Hold on, wait. There we go. Someone in chat mentioned peristalsis, so I'll write down here. Oh god, I can't write properly. Wait, hold on. Peristalsis. Ang pangit ng sulat ko. Wait lang. Let me make this. How do I erase this? What the hell? Oh. Can I not erase it? Erase all inputs. There we go. Malogene, thank you for the sub. Okay. Peristalsis. Okay. Reseta. Anong reseta? Okay, this one is an important term that I'll be using while I talk about the esophagus, okay? Peristalsis is basically the movement and contractions of the esophagus, okay? So, contractions. There we go. Contractions of the esophagus. We call it peristalsis. Or basically contractions of like the digestive system. It's called peristalsis. Okay, so I'll be using this word a lot in the slides. Okay. So esophageal disorders. So the esophagus can have motility disorders or disorders in motility and peristalsis. And one of the disorders of motility for the esophagus is achalasia. So basically this is what we saw in Kevin's VTuber asset. Okay? This is basically what we saw in Kevin's VTuber asset. So that's why I said this VTuber. His VTuber has achalasia. Alright, so this right here is the normal. This is normal. Okay, this here, this red line here is the diaphragm, okay? This is the esophagus and then stomach. Okay? So normally this is how the esophagus looks. But when you have achalasia, this is a disorder of the what you call this? Of the esophagus. When you have achalasia, you have no peristalsis. No peristalsis. That means your esophagus is not contracting. And aside from that, your esophagus is not contracting. Plus, and your sphincter, the lower or the LES or the lower esophageal sphincter does not relax. So whatever you're drinking or eating stays in the esophagus, and that's why your esophagus dilates. Okay? That's why your esophagus gets bigger. And you can see this in an x-ray. We call this x-ray or this study a barium swallow, because what they do is they make you swallow a special dye, and then they'll take an x-ray. And you can see the esophagus light up because of the dye. So this is the esophagus right here. See this? This is the esophagus right here. It's dilated. And then over here is where you can see the sphincter. It's not relaxing. So only bits of the dye is going through into the stomach. Okay. Ito po yung lalagyan ng coins. Lalagyan ng... Mods! Paki-time out. Paki-time out yung Rain. Ang corny mo, Rain. Hindi to alkansya. Akalasia. Hindi to alkansya. Time out. Buisit, para kang si Minokalo. Okay. Parang si Minokalo to ah. Yung esophagus, yan ba yung kamag-anak ni Esophagus? Mga buwisit kayo? Ano ba yan? Mga buwisit kayo? Okay. Hold on. Ayun pala si Wendell. Wendell, paki-time out ng 30 seconds yung mga Minokalo-like figures dito sa chat. Mga anak ni Minokalo. Okay, so anyway, Minions. Alright, so anyway, I'm gonna play that video, that one video again. So, ayan, ha? Pakita ko sa inyo ulit yung achalasia. This is why I said it was achalasia, okay? Because... Ano yun? Not only is the stomach and the anatomy not right, but yeah. Ayan o! Ano yun? She's regurgitating, okay? So it took a while before she's able to move. Tapos may gastroparesis pa. Excuse me. Anyway, okay. Close this. May airway obstruction po ba may achalasia? No. Remember, the esophagus is different from the trachea or the trachea or the airways. Esophagus is separate. So no. Okay. Alright, next. So that is achalasia. I know there's like different types of achalasia, but I'm not gonna cover those because in my field we don't really need to know those. That one is more on gastroenterology stuff. Because this thing you don't... Most of the time these disorders can be managed conservatively or with what do you call this? Medications. Okay? Not surgical. Rarely it would need surgical. Okay, next esophageal disorder we have distal esophageal spasm, or we call this DES in short, DES. DES. D-E-S. So basically your esophagus spasms so much it looks like a corkscrew. Okay? So, what happens is you get so much, what do you call this, spasming in your esophagus that... Look at your esophagus when you do your barium swallow. Your esophagus looks like a corkscrew. Look at this. Literally like looks like that. Okay, because of all the spasm. Okay. And if I remember correctly, you have spasming, but I don't think, if I remember correctly, there's no problem with the with your lower esophageal sphincter with the LES. So yeah, I think. Oh yeah, okay. It's more on spasms. Okay. How do you even fix that? It's medications, man. Medications. Alright, next. Absent contractility. I don't have a photo of this because these things you don't see in a barium swallow. The barium swallow can look normal, but basically the esophagus has no contractions. It's similar to achalasia, where the esophagus doesn't contract or have peristalsis, but your sphincter, your lower esophageal sphincter, is normal. In achalasia, it doesn't relax. This one does. Okay? So, basically your esophagus is not working properly. Next one is the nutcracker, or the jackhammer esophagus. I couldn't find any photo for this either, but they said, it says that barium swallows, they can look normal. They can look normal, but what differentiates this from the others is that your esophagus contracts more strongly than normal. Like I said, it has a but you know, when you're doing a barium swallow, it will look normal in the X-ray, but your contractions are very strong, and the pressure. See, the pressure of the contractions normally is 10 to 45. In a nutcracker or a jackhammer esophagus, it's 180. Imagine that. Imagine your esophagus working it out. And working it out. And that's why it's called a nutcracker or jackhammer esophagus. Probably if you swallow a nut, your esophagus is gonna crack it open just like a nutcracker. That is why. But, you know, all these things I have not seen. I actually have not seen them in clinicals. Because these are more gastrointestinal and medically managed. So in surgery, we don't really handle these. The only time we handle these things is when medical management isn't enough anymore. Or it doesn't help. That's when surgery steps in. Okay. Okay. Hold on. How do you read mmHg? What do you mean, how do I read millimeter? What do you mean mmHg? I read it as mmHg. I just read it as mmHg. That is the unit for pressure. Or do you mean like the full thing? It's millimeters mercury. Millimeters mercury. Okay. Millimeters mercury. I just say mmHg. Because to say millimeters mercury is so long. Okay. So, next, what's next? Ineffective esophageal motility. There was also no photo of this. Basically, this is just a weaker swallow or ineffective swallows, and the esophagus doesn't have normal peristalsis. Like, you just have a weak esophagus. There we go. Weak swallow, weak esophagus. So you end up like vomiting or regurgitating. Okay. So basically all those things. Oh, here we go. Here's one photo. This is the only photo I have for the stuff I talked about. Des looks like a corkscrew. Hypercontractile esophagus, or basically the nutcracker and the jackhammer esophagus. They contract so much that... And then the IEM, or the ineffective esophageal motility, it's just a weak swallow, weak peristalsis, and then absent contractility, where there is no peristalsis at all. But with a normal sphincter. Grabbing zigzag. I know, right? Just spasming esophagus. So, basically all these things cause GERD, okay? Gastroesophageal reflux. If you have these, you basically have a reflux disease. And this is treated medically. So usually PPIs, or like, omeprazole, stuff like, usually omeprazole. Now if there is no relief, like you're on meds and it doesn't help, meds are not working, then surgery is done. And usually what we do is if it's a sphincter problem, you have to form a new sphincter, basically. That's what it is. It's called a funduplication. Where you get a part of the stomach. You get a part of the stomach and wrap it around the esophagus and suture it. So that becomes the sphincter. That's one of the treatments. I've only seen this done once. I've only seen one of these procedures in my surgery career. So yeah, and I know there's different techniques, but I've only seen one kind. So yeah. As I said, these things are not common in my field. Okay. Next. Rare siya. More like rarely needs surgical intervention because it can be managed medically. Like, the first line of treatment is medical. And most of the time, majority of the time, it can be treated medically. So when it goes to, if we get a case like this and it ends up in surgery, that means it's really bad. Okay, let's go to the stomach. I was supposed to put in esophageal cancers, but I wasn't able to. Like I said, this is scuffed. I wasn't able to put any slides on esophageal cancer. But if part of the stomach or part of the esophagus of esophageal cancer includes taking out part of the stomach. They go hand in hand. And it also depends on what area of the esophagus the tumor is in. And majority of the time, or at least the first line of treatment when you talk about esophageal tumors, one of the first things you have to do is chemoradiation. Because the esophagus is very, delicate, or no? The esophagus is in a very difficult position, or its anatomy is difficult in its location. the esophagus is located in 3 areas, right? The neck, or the cervical area, the chest, and the abdomen. So, depending on where the tumor is, if it's in the upper, the middle, or the lower, that will depend. The incision the surgeon is gonna do depends on where the tumor is. So if it's in the upper esophagus, you're gonna have a neck incision or sometimes a chest incision. If it's in the lower esophagus, you're gonna have you can have a chest incision and an abdominal incision. You know. Excuse me. Gotta drink. So, as much as possible, if there is a tumor in the esophagus and it is large, you have to make it smaller or you have to downstage it. So that's why they do chemotherapy and radiotherapy to try to make the tumor smaller. And when it is small enough, it's better to, instead of doing outright surgery, they do endoscopy and try to resect the tumor. It really depends, because if the tumor is advanced staged, if the tumor is advanced, it's a stage 4. They don't resect it anymore. It's just chemotherapy and chemoradiation. Because, like I said, the esophagus is anatomically in a very difficult position, in a very difficult location. Okay, that's why. That is why I have not, or I've only seen one esophageal surgery. Because majority of the time, it is advanced. They just do chemotherapy, radiation. Surgery, not much. It's a difficult location. That's why it's really hard. Okay, next. So for stomach, okay, chat. Quality of life, yeah. Oh, here we go. Anatomy again, guys. So the rest of the slides are from my old stomach stream. My old stomach stream. Because I was supposed to change some of these, but I didn't have time, so. Again, like I said, the stomach is on the left. Or at least majority of the stomach is on the left, okay? Here. Okay. What's we got here? Oh, here we go. Anatomy of the stomach. So for anatomy of the stomach, we have the different parts of the stomach. So this part here of the stomach, the upper part is called the fundus. The fundus of the stomach. Okay? And then this part is the cardia. Or no, this part is the cardia. They call this the cardia of the stomach. And then this whole thing is the body of the stomach. This is the pylorus. Sometimes the antrum is around here. They almost, what do you call this? They interconnect. And then this is the pyloric sphincter. Okay, once you go past this pyloric sphincter, you're gonna be in the small intestine called the duodenum. Okay, the first part of the small intestine is the duodenum. So here's the esophagus. The lower esophageal sphincter is here. This whole thing is called the gastroesophageal junction, or gastroesophageal junction. Or that is also where your LES is. Okay, that's where your LES is. The lower esophageal sphincter is there. So, why do you have reflux? If your lower esophageal sphincter is not working properly, it doesn't contract, or it stays dilated, or stays relaxed, then whatever you eat, whatever you've eaten or drank, it's gonna go back up. You're gonna regurgitate. It's gonna go back up. Okay? And this is why, here's a tip for you guys. If you've just eaten, let's say you've eaten dinner. It is not advisable for you guys to lie down right away after eating. Because your stomach is full, your stomach has food, there is a tendency for you to regurgitate, okay? Even though, if I remember correctly, when you're lying down, your sphincter actually is supposed to tighten because it's gonna feel the food coming up. But if you have a GERD, if you have gastroesophageal reflux, you're gonna vomit. You will end up vomiting. If your sphincter relaxes and you're lying down, you're gonna regurgitate, okay? And that is why also, let's say you have to lie down. You wanna lie down after eating. For some reason, you wanna lie down after eating. The best side for you to lie down on is your left side, okay? Why your left side? Because the fundus of your stomach is on the left side, right? So if by gravity, if you lie down on the left side, the food is just gonna stay here in the fundus. You won't vomit, okay? If you lie down on your right side, then your food goes to the right of the stomach here, and you're definitely gonna vomit. Or if you have GERD, you will vomit. Okay? Alright? Oh my gosh. Wait, hold on. I need to charge this. Hold on. My iPad's about to die. Hold on. That makes sense, yeah. What is the survival rate when what do you mean by what is the survival rate? There is no, like, it depends on what your stage is. Depends on the patient and how advanced the cancer is. It's not the chemoradiation. It's how advanced or how bad the cancer is. Okay. So far you guys get it? You guys understand, right? About the stomach leaning on left or right. But, you know, in general, don't lie down after don't lie down after eating, okay? Don't lie down after eating. You have to, the advice, if I remember correctly, the advice is at least 2 to 3 hours after eating before you lie down. Okay? What is the concentration of HCl in the stomach? If I remember correctly, concentration is 0.5%? 0.5%, I think. Okay. Next. Okay. What is the purpose of the stomach, chat? I'm gonna ask you questions now. What is the purpose of the stomach? What do you guys know about the stomach, chat? To be toxic. Absorb nutrients from food. What else? What else, chat? Makes puke. Makes puke, bro. All right. Break down food, digest. Okay. Okay. None of you actually said storage. None of you said storage. Okay. Temporary storage of food, okay? The purpose of the stomach is to store food. Temporarily. And yes, you have mechanical digestion or breakdown of food in the stomach as well. Absorption. Someone said absorption. Absorption is more on the intestines. Not the stomach. The stomach is more for storage and breaking down. So, the stomach is a very acidic location in your body. It produces it releases or secretes a lot of enzymes and acids to digest food. That is why when you vomit, it's sour. Because of all the acids. That's why it's nasty when you vomit. Because of all the acids and enzymes digested. Okay? It is, the nasty stuff. Doc, ano yung pepsin? Oh, okay, here. Do I have it here? Oh, no, I don't. Okay, I don't have it here. Shoot, I was supposed to put that on my slide. There was supposed to be a table of all the enzymes. Pepsin is an enzyme, okay? There are multiple... like, for those who are in the medical field, you have to know the enzymes in the stomach, and there's a lot of them. Hold on. Enzymes. I'm going to... Hold on. Let's do this. I was supposed to show a table for that, but I wasn't able to. Alright, there's a table for this. Where is it? Major digestive enzymes. Oh. Where is it? Oh no, this one covers intestines. I need stomach. Pepsin is the one enzyme in the digestive enzyme in the stomach. Where is it? There is a table. Ito ba yun? Oh, this is okay. Here we go. Enzymes. Digestive. Okay. And also the type of cells, too. You have to know the cells in the stomach and the type of... Okay, here we go. I think I found this. Is this the one? Okay. Open image, new tab. Okay, here we go. Where is it? Here we go. Here we go. This is it. There are different cells in the stomach, okay? And, you have to know these. There's a mucus cell, the parietal cells. This is supposed to be parietal cells. I don't know, it's parietal cells. Enterochromaffin-like cell, chief cells, D cells, G cells. These are the cells in the stomach. And they secrete, and each one secretes certain substances. So, the mucus cells just secrete mucus or bicarbonate. Parietal cells secrete the gastric acid or the hydrochloric acid. Okay, and intrinsic factors for calcium absorption. The enterochromaffin cells secrete histamine. Okay. Chief cells are the ones that produce the pepsin. And they also produce gastric lipase. So these are the ones... Gastric lipase and the pepsin are the enzymes of digestion in the stomach. Okay? There's also the D cells, which secrete somatostatin. This is a substance that regulates acid secretions. Because, you know... if your stomach hyperproduces acid or keeps producing acid, you're gonna end up with ulcer. So, there is a counter so that's why the somatostatin is the one that counters that to regulate the acid secretion. So what somatostatin does is inhibits acid secretion, and you have the G cells which secrete gastrin, which stimulates acid secretion. Okay? This is an important table. I think, if I remember correctly, in med school I think they asked us in med school. They also asked us in surgery. So, important table. Doc, ilang TB yung storage? Pepsin... Ba't ang kokor ninyo? Ang kokor ninyo! Ang kokor ninyo! Alright. Next! Okay, I think we're in diseases. I think this is diseases now. Peptic ulcer disease, basically acidity. Hyperacidity, leading to an ulcer in the stomach. Do any of you guys have a... Are any of you guys diagnosed? Like, actually diagnosed or self-diagnosed with hyperacidity or peptic ulcer disease or anything like that? A lot of people, I know a lot of people have this. Like, you know you have it when you're eating or drinking caffeine and your stomach hurts. You drink a soda, your stomach hurts. You take something and your stomach hurts. I got ulcer once back in high. Oh, I have to eat Jello for weeks. Okay. Reflux. Oh, you got reflux. Oh man. Okay. Causes of hyperacidity. There's different causes. Number one cause of ulcer, hyperacidity and gastric ulcer, is a bacteria called the H. pylori excuse me, the H. pylori bacteria. My God, naubo na ako. Or H meaning Helicobacter pylori. Helicobacter pylori bacteria. Okay? That is the most common cause of gastric ulcers. So, yeah, you have to, every time a person is diagnosed with a gastric ulcer, you have to rule out H. pylori because they're the most common and there's a specific treatment for this. It's a triple therapy. You have to take like 3 antibiotics for this. You gotta take 3 antibiotics for an H. pylori infection. Helicobacter! Bakit kasi, Helicobacter! The helicopter! Helicobacter, not helicopter, okay? Helicopter. Okay. NSAIDs. NSAIDs is basically, non-steroidal anti-inflammatory drugs, usually pain relievers. These are usually pain relievers. Paracetamol, Tylenol, ano pa? Celecoxib, Etoricoxib. Basically those. Okay. Caffeinated beverages. Okay, this one I put 2 asterisks here because some people say this can cause, but I read it up some more and it's more, this one is more on aggravates caffeinated beverages more aggravates the ulcer or the hyperacidity more, but not really cause. They don't really cause it, but they aggravate it. So that's why when you have an ulcer and you drink a caffeinated drink or a caffeinated beverage, your stomach will hurt because it aggravates it. Okay? Tapos yung mga may bisyo, smoking alcohol. Yeah. And there's also such a thing as stress-induced ulcers. Okay? It happens. But the number one cause is still H. pylori. Okay. How many more slides? I think this is a long one. Okay. Next. Oh, diagnostics. Okay, here we go. Diagnostics. Okay, diagnostics. We have... There we go. Endoscopy or EGD. Okay. So, endoscopy or EGD or esophagus. So I put the whole name. EGD. This is basically a scope. Okay, they look into you. It's a scope. They sedate you, insert a scope through your mouth, and then they examine your esophagus, your stomach up to the duodenum. Okay, they examine it. Is tramadol NSAIDs? No, it's not. But it's not an NSAID by itself. But usually tramadol is combined with paracetamol, which is an NSAID. So yeah. I ain't reading all that. Just EGD. That's it. Endoscopy is the shortcut, or just EGD. Yeah, the cable. Okay. Oh, okay. And also for diagnostics, if the patient does have an ulcer, what they do is they take a biopsy and they send the specimen also for H. pylori testing, because you have to rule out H. pylori. And if it comes out positive, that's when they start a triple therapy of antibiotics. And if confirmed also with ulcer or hyperacidity, you have to take medication. So basically, gastric ulcers are managed medically. Okay? So avoid the offending factor agent. So what is causing or what is aggravating your gastric ulcer? Caffeine. You gotta stay away from caffeine. Stop drinking it. Stop drinking for a while. Stop smoking. Stop drinking alcohol. Stop being stressed. Stop being stressed, man. Antibiotics against H. pylori. Okay. The antibiotics for H. pylori, if I remember correctly. Oh wait, it's not triple. Wait, no, I was wrong. It's 2 antibiotics and 1 PPI, not triple therapy of antibiotics. For when you treat H. pylori, you take omeprazole. It's called a triple therapy. Triple therapy. This is the basic one. So omeprazole is 1. Okay, so triple therapy omeprazole, which is once daily. And then clarithromycin. And metronidazole. Metronidazole is usually 3 times a day. Clarithromycin, I forgot. I don't know if this is 3 times. I don't remember if this is 3 times a day. Because if I don't give clarithromycin, I can give amoxicillin. Mahirap yung stress. If only were that easy, I know. I'm stressed every day. Don't worry about it. I also get stressed, guys. I'm a surgeon. Is there a cure for your cough? I'm worrying. Oh, don't worry about my cough. It's actually better than before. Like, here's the thing about my cough. When I first had this cough, I had a lot of phlegm. My throat hurt. And I couldn't, reach higher. I can't make a higher pitched voice. So it's slowly recovering. I'm only coughing because I still have like something irritating my throat. It's not itchy anymore. It's not painful, but sometimes you feel like something dripping down your throat and it just causes you to cough. So yeah, when I get cough or colds, it takes a while for the cough is the last thing that goes away. How do you know, Doc, if it's H. pylori? There's a test for that, an H. pylori test. You send a specimen from the stomach, from the ulcer, you send it to the lab, and if it comes out positive, then it's H. pylori. Okay? But yeah, if you have hyperacidity, omeprazole. Okay? Like, if you do not have H. pylori, let's say your ulcer is not caused by H. pylori. If it's not caused by H. pylori, just avoid the offending agent. Avoid the offending agent, and then take acid suppression medication. So that's omeprazole, all that, antacids. Okay. Next. Okay. Now, let's go a step higher. You have gastric ulcer and it starts bleeding. What do you do? So this is a complication of gastric ulcer. So you have an ulcer and it starts bleeding. Okay. This is a complication, or one of the complications. It can be treated conservatively. Sometimes the bleeding can stop by itself, but it depends. The next line is an EGD or a gastroscopy, endoscopy. Oh. Why is there symptoms? Oh, okay. Oh, here we go. Bleeding. Okay, symptoms. Yeah, the symptoms: vomiting blood. You vomit blood! Oh, okay. You also get black poop, which we call melena. If your poop is black, like this, if your poop is very dark, a little darker than this, it's like a black, we call it black tarry stools. Or black tarry poop. We call this melena. Melena is... If you have a melena, or that kind of poop, that means you are bleeding in your upper gastrointestinal tract. Okay? It means you are bleeding. But if you poop out fresh blood, like it's bright red, we call this hematochezia. Okay? And when you have hematochezia, it means you're bleeding in the lower gastrointestinal tract. So this is what we call UGIB, or for melena, you have UGIB, which is upper gastrointestinal bleeding. For hematochezia, it's usually LGIB, or lower gastrointestinal bleeding, okay? These are very common terms that you're gonna hear when you're in the medical field. LGIB, UGIB. Especially in medicine, because they deal in internal medicine or gastroenterology, they deal with these a lot. Okay? Alright, next. Oh, diagnostics, here we go. Okay, as I said, EGD. If you have bleeding, you need a if you have bleeding, bleeding ulcer, of course, it's an urgent thing. It's an urgent matter, okay? Because you have to make sure that that bleeding is not continuous. Because you can bleed and then it stops. That's good. But if you're bleeding and it's continuous, then that's when it gets bad. So, you know, if you have a patient that's bleeding, you have to control the bleeding, and you have to transfuse blood, because the bleeding can be very bad or very severe that you lose blood. So endoscopy is one of the ways. You have to search for the bleeding and stop it from there. Oh, here, blood test, blood transfusions. Treatment. EGD again. Acid suppression, so omeprazole, blood transfusion. These are like first line, or the first things you're gonna do. Oh, okay. Now what if you're not able to... What if you're not able to control? We did EGD. We transfused blood, we did all these, and he is still bleeding. The patient is still bleeding. Patient is still bleeding despite everything we're doing conservatively. Oh, that's when they're gonna... When that happens, that's when they're gonna be referring to surgery. Hey, surgery, we got a bleeding ulcer. What we do? So, if all else fails, and they refer to surgery, and the patient becomes surgical, we have to do a exploratory laparotomy, and let's go back to the stomach, that bleeding stomach. Okay. One of the things we're gonna do is, if it's a small bleeder if it's a small area that's bleeding, what we can do is just suture over it. You can suture it to stop it from bleeding. Sometimes that's all you need to do. Just sew it. Wait, hold on. Okay. Oh my gosh, it's been 1 hour and 1 hour 30 minutes. This one is a long what do you call this? Lecture. Okay. So, one of the things you can do is just suture over it. If it's too large, or another option is to remove that part of the stomach, like resect it, excise that area, and then sew it together. Yeah. Okay. If the patient is stable, and another option is to there is this I don't know if I don't remember if this is in the later slides. There's a thing called vagotomy. It's basically snipping a certain nerve. This nerve will lessen. If snipping this nerve is going to lessen the overproduction of acids. So in a way, it, so that you don't have the hyperacidity anymore. And this procedure, the vagotomy, is... I have not seen this in actual. I have not seen this in actual, so I won't be able to describe it. This is very rarely done. I have not seen it. Another option, if the ulcer is so big, let's say it's a really big ulcer and it's bleeding, you have to do... You can't just take out the area. You have to resect a portion of the stomach because of how big it is. So, yeah. Okay. Alright. Okay. So bleeding ulcers is something I don't see much, but what I see more often is perforated peptic ulcer disease. So this is basically your ulcer, not just bleeding, it perforated your stomach. You have a hole in your stomach. Here. So whatever food you have in your stomach leaked out. Okay? Everything leaked out. So it's in your abdomen. And all your acids are there in your abdomen, outside the stomach. This, my friends, this, my supporters, is an emergency. This is a surgical emergency. Okay? When we surgeons talk about a perforated peptic ulcer disease and the patient is septic, that means you better get that patient to the ER, to the operating room as soon as possible, or he is going to die within a few hours. That is how emergency it is. Okay? Do you perform vagotomy, or it's done by a general surgeon? Done by a surgeon, not a neurosurgeon. Okay, so symptoms: abdominal pain. Oh, that's it. Abdominal pain, sometimes in perforated peptic ulcers. So it's really severe. The abdominal pain of a peptic ulcer disease is bad, but once it perforates, it's worse. Okay? And the longer, and it is a pain that gets worse and worse over time. It is a pain that does not go away. Like, it's really severe. Like, your whole stomach is gonna hurt. First, it'll start on the area where the perforation is, and then it'll spread all over your stomach. And, if they don't go to the hospital right away, so they keep waiting, eventually they will start having fever. They'll start having fever, they'll get dehydrated, and septic, basically. Will the patient be slightly yellow? Yeah, if they're septic, if they're really septic, they can turn yellow. But not everyone does. It can happen. Diagnostics. Okay, one of the first diagnostics in this. So if your doctor or if you have a perforated peptic ulcer disease and your doctor suspects that it's a perforated peptic ulcer disease, one of the first things they're gonna request for is a chest x-ray. Okay? A chest x-ray, not an abdominal x-ray. It's a chest x-ray that is upright. And, well, aside from... And oh, here we go, we got one! Okay. Why a chest x-ray? Okay. What's this? Okay. This one is a normal chest x-ray. Alright? Yeah, this is a normal, and this is the one with peptic ulcer, perforated peptic ulcer disease. Okay. So when you have a perforation in your bowels or the stomach, whatever is inside that bowel is gonna spill out, including air. Stomach has a lot of air. This is why you guys burp a lot. Okay, it has air. So if you have a perforated stomach, the air comes out. And you will see it in the x-ray here. This is the air. Okay, that little bubble there. This here, this line, is your diaphragm. Okay, is your diaphragm. Like this here. There we go. This one right here. This is the diaphragm. Oops. Okay. Anyway, that's the diaphragm. And this right here, where the black arrow is, that is air. Because in an x-ray, white means that something is dense or solid. Black is fluid. Okay, black is fluid or air. So, yeah. That's why the bones are very white. And the lungs is darker because it's full of air. So here you can see the air. If we see this... this is a medical emergency. Especially when they are in pain. If we see this and they have abdominal pain, That is a surgical emergency. Because this is not supposed to be there. This is a normal x-ray. You can see there is no air there. This is the normal. You're not supposed to have that. So, we surgeons, if we see this kind of x-ray on a patient that is complaining of abdominal pain, the bells in our heads are gonna start ringing. Hey, this is an emergency. We gotta get this guy to the OR stat. Okay. What is septic shock? How do we say it? It's for short, it's a shock caused by infection. A lot of things happen in septic shock, and basically it's like a complication where your blood pressure goes down, you have fever, your heart rate goes up, and it's caused by sepsis, which is an infection. Caused by an infection. If you want more information on that, I think I covered shock in one of my old streams. My VODs. You can check that out. I know I covered that. It's a long discussion, okay? Alright. You can just check out my other medical education streams for that. Alright, next. Diagnostics. Okay, another diagnostic aside from X-ray is the CT scan. But usually we don't need to do this. X-ray is enough. We don't need to do a CT scan. Unless you're considering something else. Unless you're thinking it's not an ulcer. If you're thinking it's a tumor that caused the perforation, then sure, go ahead with the CT scan. Konbanwa, Dokta. Hello, Ruki. Hello. Okay, there we go. Treatment is surgery. Emergency exploratory laparotomy. So, most of the time when I get patients like this with the perforated peptic ulcer disease, they are septic and they are not stable. Like, they have low blood pressure. They are hypotensive. They would be like 90, 80 over 60. Their heart rate is like 120. They are febrile. That kind of thing. So, when the patient is like that, it's a fast in, fast out. Like, bring him into the OR as soon as possible, and you have to operate quickly. And the fastest operation you can do is omental patching. This one, omental patching or the Graham's patching. The other one, this is a definitive surgery, is a partial gastrectomy, or where you take out a part of the stomach where the ulcer is, and then you do a vagotomy. Okay? Here we go. I will explain Graham's patching. Oh, oops. I will explain Graham's patching, so... This black dot, imagine your ulcers right here. This black dot is the ulcer. Okay, this one right here is the ulcer. You have an ulcer right there. When we open up the patient, we're gonna see this. What we do is we drain all the fluids, because definitely when you open up the patient, you're gonna see a lot of shit spilled around the abdomen. Rice, food particles, acids, beer sometimes. Usually, most of the ones I've operated on, they drank beer, so you can smell the beer mixed with acid, and it's disgusting. You're gonna have to wash the whole abdomen, suction out all the fluids and all the particles, take out all the particles. And then, you're gonna look. You have to, so... After that, you look for the hole, for the perforation. Usually, the ones I've seen are in this area. They're usually here or over here. They're usually here or here. You also have to look behind the stomach. At the back. So you have to access the back of the stomach and to make sure that there's only one hole. Because sometimes there could be more than one. Okay. So, there are two ways to do a Graham's patching. Because there's the traditional one. and there's a modified Grams patching. If I remember correctly, Grams patching is when you lay down sutures. So what you're gonna do is you're gonna suture this closed. Suture. You're gonna suture this closed. And then with the remaining threads, you're gonna get a piece of fat. See this yellow? This is called the omentum. The yellow stuff. This yellow thing. This one. Is yellow. This is a omentum. You're gonna get a piece of omentum. There we go, that one. And then you're gonna place it on top. You're gonna place it above the suture. So like this piece of omentum, you're gonna put it on top of the perforation you sutured. Like a little, it's like, let's say it's gonna be like this. Flappy, like that. And then the ends of the suture that you use, you're gonna tie it again. So it's basically like suturing something closed and then putting a piece of fat on top of it and suturing it on top of it. That's what it is. Okay, that's what it is. That's the traditional Grams patching, if I remember correctly. If we talk about the modified one, modified is you don't suture the hole. You're just gonna put the fat directly on top of it and then suture it together. That's it. That's the modified. And according to researches, they're both effective. It doesn't matter which one you want. They're both effective, and it just depends on the surgeon which one they want to do. Okay? Yeah, it's fat. Will fat be dissolved by HCl in the stomach? No, you don't put this inside the stomach. You're gonna drain everything, you're gonna close the hole, so... yeah. So, you just seal it up. Okay? That is the emergency surgery for that. And I've done a lot of these. Because this is pretty common. Kinda. Okay. Oh, there! Fat! Basically, that's how it's gonna look like after. This is how it's gonna look like after. And then just, like, sutures on top of it. Suture. Yeah. Okay. Here's another image. So, see, you suture it closed and then put fat on top, basically. The other one is just putting the fat on top of it. Okay, that's it. Now, what if what if they need a gastrectomy? What if you need a gastrectomy? You're basically this is a gastrectomy, so instead of tumor, let's say it's an ulcer, it's the same thing. You're gonna cut a portion of the stomach. You have to suture it together. So you're gonna suture an end of the intestine here. This one right here. You're basically, it's like making plumber. Reconnecting things like tubes. Okay. Vagotomy is when you snip that nerve I talked about, which lessens acid secretion. So the thing about perforated peptic ulcer disease is you have to know what caused it. If it's H. pylori, if it's H. pylori, you have to treat after the surgery. They have to have the regimen for H. pylori, the triple therapy. Now, if the cause is something else, like stress, wag ka ma-stress. You know. They even have, do I have it here? Oh, here we go, there we go. There's different kinds of vagotomy. See, these are the nerves of the stomach. Truncal vagotomy, if I remember correctly, they do a truncal vagotomy. So, it's just snipping this. It's this one right here. Selective, you pick out the nerves, and then highly selective is like each nerve per area of the stomach, which is a lot harder. And this is why I have not seen this done, because this is actually a very this is a complicated procedure. It is hard. Hard. Okay. Okay. I don't have it here. How do we know if the cause of the ulcer, is hypersecretion, hyperacidity hyperacidity, or NSAIDs, or H. pylori? Like I said, take the test for H. pylori. If it's negative, then it's either hyperacidity or NSAIDs. NSAIDs, all you gotta do is ask the patient if they've been taking pain meds like candy. Because that's usually the case. They're taking it like it's freaking candy. Like, may masakit kasi they have like arthritis or something, so they take their celecoxibs like 3 times a day or something every day. Then yeah, they're gonna get ulcer. Like, celecoxib's supposed to be twice a day, by the way, guys. Okay? And then hyperacidity. Because if it's not this, if it's not H. pylori, it's not NSAIDs, it's most likely hyperacidity. Okay? And then you need a vagotomy for that. Okay? Holy crap, it's 1:47. I have been going for 1 hour and 47 minutes. Okay, I think I'm almost done though. Let's see. I don't know. GERD! Okay, gastroesophageal reflux. I talked about this in esophagus, so I think... See, look. What happens? Your sphincter isn't relaxed. Your sphincter relaxes, and the food you eat just goes up, and you vomit. Okay. Ayan. Symptoms of GERD: heartburn. Someone asked if it's related to the heart. It's not. They call it heartburn, but it doesn't affect the heart. It just feels like chest pain, but it's not. That's why when a patient has GERD or esophageal motility disorders, sometimes the symptoms is chest pain, which is it's basically heartburn. That's why for people who have this, or if you are considering GERD or if you're considering GERD or esophageal motility disorder, you have to rule out heart problems, because they can be similar in terms of symptoms. You have to rule out heart problems, because they could have chest pain, and it is caused by, the GERD, but it can also be, the most common, which is a heart problem. So you gotta make sure, if they have chest pain, but there is no heart problem, and they have, reflux, they're regurgitating, then yeah. Okay? Chat, so far, are you following me? I didn't realize that I am taking long with this one. I hope you guys are learning stuff. I think I'm almost done. I think the next one is cancer, is it? I hope you guys are still learning. We're still alive and holding our stomach. Okay. Alright, I'll try to speed this up a bit. Symptoms, so heartburn, stomach pains, abdominal pains, vomiting or regurgitating, bloatedness, yeah, you feel bloated. Okay, diagnostics, EGD, the best! Favorite of this topic, favorite diagnostics of this topic is EGD. Scope. There's also this, a 24-hour esophageal pH monitoring. So, they just check the acidity. Treatment, okay. Treatment for this is conservative. Lifestyle. Stop smoking. You smoking? Stop. Mataba ka? Magpapayat ka? Mag-exercise ka? Do you tend to eat large meals at a time? You gotta lessen that. Konti-konti lang. Oh, there we go. Avoid lying down within 3 hours of eating. And remember, lie down if you need to lie down. If you need to, you lie down on your left, okay? You need to lie down on your left. Yeah, omeprazole, syempre. Omeprazole is the magical drug in this. Omeprazole is the magical drug for this topic. Omeprazole #1. What's this? Oh, okay, this is the one I talked about. The funduplication. Where, remember I told you? What they do is they get a piece, the fundus of the stomach, and they wrap it around the lower esophagus. Like this, and then you suture it together. It becomes like the sphincter. That's the one. This is a Nissen funduplication. Nissen funduplication. That's what we call it. I've only seen one. Right. Oh, okay, cancer. I think I made this straightforward. So, cancer, it can occur anywhere in the stomach. Depending on where in the stomach it occurs, that would be the treatment. The treatment depends on where in the stomach it occurs. So if it's here, the tumor is here, all you gotta do is just remove you do a subtotal distal gastrectomy. If the tumor is higher up, it gets a little more complicated because you would have to reconnect the stomach to the esophagus. That's harder. Survivability rate of gastric cancer, it depends. How advanced. Because if it's a lower stage, then you have a higher chance of surviving. It depends on the histology of the cancer. Like if it's it depends on the histology of the cancer, the type of cancer, the location, and the size, and if it's scattered to other areas of the body, or the lymph node invasions, stuff like that. It really depends. Here we go. Oh, okay. So if your tumor is here, see, you only need to do a subtotal gastrectomy. So just part of the stomach, remove this, and then you close the duodenum, get a piece of the jejunum or the distal part of the esophagus, connect it to the remaining stomach. And they call this a Billroth 2. Distal gastrectomy with a Billroth 2 gastrojejunostomy. See, I have to know these names. If the tumor is higher up, like here, see, you have to remove the entire stomach. And you're going to reconnect the intestine to the esophagus. Okay. There's also other reconstructions or other types of surgery for this. But yeah, I have not seen it. I actually have not seen that. I have not done it yet. I have not seen it in my residency. Is there a stomach transplant? Yeah, I know there is. There's pretty much a transplant for almost any organ, but we don't have that. I don't think we have that here. You would only see that in like really advanced institutions. But a stomach transplant, that is not yet a norm or like a go-to treatment. Because I think there is, but I'm not sure, okay? Because but you can theoretically you can transplant different organs into your body. But you would have to, the thing about it, the thing about transplant is it's not just connecting an organ, not connecting the main organ to the body. You also have to connect the blood vessels. So theoretically it's possible, but it might not be, it's not easy. And because it's not easy, it might not even be worth doing it, basically. So yeah. Right. Compatible? No, more like you have to reconnect the blood vessels. Yeah, there's also compatibility. Yeah, actually, just like kidney transplants. Okay. Oh, that's my last slide. Okay. That was my last slide. All right, we took a long time. We took almost 2 hours, guys. Actually, we took 2 hours. All right, guys. Any questions? I hope you guys learned stuff. How do tumors form under the influence? What? Under the influence of what? How do tumors form under the influence HCl in the stomach? Tumors or cancers? It's cancers is something like genetic or any. If you have an ulcer and it's been there chronically, it can eventually turn into cancer. So do you need an immunosuppressant drug for transplant? You know, actually transplant is one of my what do you call this? One of my weaknesses in surgery. I think you do. Not really immunosuppressant, but like you really have to watch out for all these what do you call this? Possible complicated reactions. Cancers super duper generally have a higher risk of popping when there's that's why when you have an ulcer, usually a gastric ulcer is something it can be a chronic thing, so it's like a wound that keeps, you know, it heals and then you get a wound in the same area again, it heals, you get a wound in the same area, it heals. You know, it's the fact that chronically, like for a long time, you get wounded and then it heals, wounded, heals, wounded, heals. It eventually turns into cancer. Like it would be this is more like like what do you call it? Cellular level. Cellular level, man. You know, dysplasia. There we go, dysplasia. You get dysplastic. The area can become dysplastic and then eventually lead to cancer. But that's another discussion. This is so med school. What's this? For a perforated ulcer, do you find the hole visually or do you blow it? No, you find it visually. You don't blow into the stomach. No, that is very unsterile. No, you find it. You really have to look for it. Like you hold up the stomach and feel and look visually for the hole. I'm very concerned with your cough. Don't worry about my cough. Don't worry about it. I'm okay. More healing means more chances of error. Yeah, there we go. More chances of error in the DNA copy. Yeah, and then it would lead to dysplasia. Dysplasia is basically how I would just define it as like kaguluhan. Kaguluhan ng mga cells. Parang ganun. It just gets messed up cells basically. Ginawang plastic balloon. Nah, yeah, you don't do that, bro. Don't blow to the stomach. Alright, so, that is all. That is all, chat. Let's see. Da, 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 da. Let's go to... Where's my... There we go. Hold on. Hold on, chat. Wait. Stick this out. There we go. There we go! Okay. Did you witness or get involved in surgery with a bypass machine? What do you mean by a bypass? You mean bypass machine? What do you mean by bypass machine? Do we have a chance to copy your PowerPoint? No, you can't have my PowerPoint. I cannot send you my PowerPoint, chat. I'm gonna end up doxing myself. This is why it's a stream. You can go back to the VOD and watch it. You can come back to my channel and just watch the VOD. It's a stream. It's gonna stay in my channel. Don't worry about it. If we can't have the PowerPoint, can we have you instead? Oh no! Oh no, don't, yeah, you know. You see, I can't give myself to just one of you. I have to give myself to all of you because you are my supporters. Bypass machine? Do you mean by like the heart and lung machine? But that's for like heart. That's for heart surgeries though. I don't know the what do you mean by the bypass machine? I miss Doc already. Diyos ko naman, Minukalo. May mga anak ka, Minukalo. You have children in the chat. You have your own children in the chat, by the way, Minukalo. Kasi ang corny ng mga jokes mo, pati sila naggaganyan din. Organ merch. I already have a special dog standee. Oh my god, you guys. You know, I wanted to... I know I owe everyone, like, another standee auction, but, you know, ever since COVID, ever since 2022 or something, it's been hard to really find someone to booth in with to sell merch. So, I am unable to really sell merch. I am not unable. It is hard for me to sell merch in cons now. Because you see, you know how the trend is, I mean, a lot of the PH VTubers or the other VTubers already, like, you know, they are comfortable with showing who they are. I, on the other hand, would like to keep my anonymity. So that's why it's hard for me. That's why it's hard for me. I'm trying to find a way, and the only way I could is really by online shopping. I don't want to, like, you know. Where do I get the standee? I haven't produced any. So it's usually by auction, so I don't have any. If you want an acrylic standee though, like the small ones, I have some, but I just have not fixed my gank shop yet because there are still, you know, I'm trying to produce mugs. The problem is the people. When I have the mug produced, the quality is really bad. The quality is bad, and I don't want to sell a bad quality mug. So I'm trying to look for a good quality one. The printing is just terrible. Like the past, I got a test copy, and it's ugly. It's ugly. I want you guys to get nice ones. Okay, what's this? What is the best choice of pre-med when you have a plan to pursue med school? My pre-med was BS biology. Some people take psychology. I know if you want something related to medicine, if you want a course closer to your field, you can take nursing. Because in nursing, you will be exposed to clinicals. And you will have an early exposure to patients. At least in that aspect, you will learn patient rapport and all that. But if we're gonna talk about academic, because before you get into clinicals in medicine, you have to go through the academics of it. You can take a course. I think nursing also has the. Does nursing have the? I think nursing has some subjects that is also in med school. You definitely have anatomy. Mga ganun. Might as well take something like nursing or medtech could work. I know some people who took PT, physical therapy also. Naka 2:40 p.m. Yeah, something like that. The print is also not good. It's like too light. It's not vivid. That's a problem. Unrelated topic. What's your feedback on Gura? God, we're gonna talk about Gura. I mentioned it on my Twitch stream. Okay, I mentioned it on my Twitch stream. A lot of VTubers are graduating from HoloLive. Yes, it does make me question what is going on in HoloLive that is causing these talents to graduate. But it's not a question that is thinking of a negative. It's more like, what is it that they are doing in HoloLive? What are the changes that they are doing that is not in line with what the talent's goal? Something like that. It doesn't mean that I am thinking, oh, they must be doing something bad to the talents. It's more like they had a shift in goals, and the talents cannot follow that anymore, and that's why they have to leave. That's what I'm thinking. And I don't know what it is, but that's what I feel about it. That's why I think Gura is, there's a disagreement with management. I think it can be that. I don't know. I don't know. I don't think about it's something because they fought. It's because they don't take care of, those kind of things. I don't think about the negative. I think about there was just a change in direction and they have to go their separate ways. Something like that. You enter this company, that startup company, and I can stream. I want to play games. Okay, stream with this work with this company, play games, and then suddenly along the way, after a long time, you have this company meeting. Okay, we're getting bigger, or we're growing. We need to. As a company, we need to change our direction a bit. We need to do more. We need to do more things now. We have to, step it up, basically. We gotta step up. And that stepping up requires more work from the talents. So, it's if we're gonna think idle, if you're a talent that entered the company thinking that, I can survive here, I can go to this company, play games, be my gremlin self stream, sing some songs, and it's okay. And then suddenly, like along the way, while you're growing with the company's okay, we have to do more. You're gonna have to start dancing, or you're gonna have to start doing all these things. You know, it can burn you out because it's something that is. It was something you didn't expect to do. You know, it was something you didn't expect to do. That's what I think. So it can burn you out, and I think that's what happened. That's my opinion. I may be wrong. What else do we have here? Better view it as an employees wanting to move forward with their career of sorts. So yeah, something like that. They forget Hole is an idol group. Yeah, I was pretty. I know they started or they wanted to be an idol group. Do you have any suggestions on things that help you practice suturing? Yeah, get a needle holder. Get sample or expiring needles, and then you get one of those. You can practice suturing on a sponge, by the way. You can practice suturing on a sponge, or you can buy one of those silicone things, suture practice sets from Shopee or somewhere. Some of them just want to stream, not do the idle training. Yeah, something like that, you know. How fluent is your Japanese? I'm not fluent. I can understand a bit, but not fluent. I want to. I want to be fluent. I want to learn. I used to self-study Japanese, but yeah. I don't. I stopped when I started medicine, so well, I started as an entertainment cover this direction to becoming more idol-like. Yeah, I think that's what happened. Expecting a weeb to dance. Yeah, it's like me joining, like me. I am a doctor. I want to stream video games. I enter a company. For some reason, I get accepted, and I can be what I'm doing. I can sing some songs. I feel like I can sing some songs, and then suddenly they're like, "Okay, we gotta do more. You gotta start dancing." I'll be like, "What? Wait, I can't. No. Can I not do the dancing? I just want to play games, and I'm okay with singing. Is that enough? You know. Can I opt out?" So if it's something, you know, yeah. Can you practice on meats? We practiced anastomosis on pig intestines. Anastomosis is when you suture intestines together, like reconnect them. We do that on pig intestines. That's how we practice it. Yagu once said back then in the past that he's trying to copy the AK-B48 idol group that became a meme. Oh! Yeah. I think, like, they wanted to be an idol group, but they needed to grow a little, and they just accepted whoever. And they're finally in this, at this point where they can start concentrating on idol things, so yeah. Okay. So yeah, that's all. I bet Doc us your patients will have 100 times more energy seeing you dance. I'm not a dancer. I can sing. I had a little bit of training. Well, like, not really training, like exposure with singing. But dancing? I feel awkward when dancing, so I don't know. I haven't even done my like full body. Oh my god, I have to check out my 3D model if it's okay now. I forgot to check it. I have to freaking check that. I have my new 3D model. What benefits would a VTuber get on joining a VTuber company at the first place? Oh, there's a lot. There's a lot. I wouldn't downplay a company. You get a lot from joining a VTuber company. Especially if it's something as big as like Holo or Niji. Or like Bishojo or whatever large company. You get, aside from like one, you get an audience, a large audience, almost immediately. You just debut and you have, what, hundreds, thousands of viewers? And then it's up to you to maintain those viewers. So you just instantly get viewers, not like an indie, where you start from scratch. Like, not every indie that debuts has that much has that many viewers. A lot of indies start off with like 1 to 3 viewers. 1, 2, 3 viewers. I started that way. I started with 1 viewer. I started with 1 viewer, and that viewer was myself. And then, another advantage or benefit is merch. Easy merch. Easier to get merch. There's also legal backing. You know? PR. There's PR. There's a lot. You have a manager that can manage other things for you. Manage your socials, manage your whatever. There's a lot. Don't worry about viewers, Doc. You got us. Yeah, I'm not worried about that. Like, I mean, it's not something I don't. When it comes to growth, I didn't want my growth to be instant. Because I think back then, if I had started and my growth was instant, I don't think I'd be able to handle that. I would prefer a slow, steady growth. So, like, I can gradually ease in. Like, start small, get used to things, and then, you know, just grow from there. I think it's easier that way. We will always be supporting. Thank you. That's very sweet of you guys to be saying that. That is why I keep streaming and keep, you know, VTubing. Even though I'm a doctor doing all these things. Even though it took me 5 years. Even though it took me 5 years to get YouTube partnership. Bruh. Every year, I would say, a New Year's resolution, become YouTube, monetize my YouTube, and it doesn't happen. It's only happened now. So yeah, it's a big achievement for me. For others, it's probably an easy achievement to get YouTube partner, but that's because probably a lot of them stream on YouTube more. I'm more at Twitch, okay? I stream more on Twitch. That's why it was harder for me to get YouTube partner. Because I could not focus on 2 platforms at the same time. I could not focus on multiple platforms at the same time. And I did not want to do what do you call that? Restreaming or multi-streaming. I don't want to do multi-streaming. That's why. I refused to do multi-streaming. I was like, I will only stream in 1 platform at a time. I don't want to do it at the same time. And that's why, yeah, it took a while. Now my next goal is to get Twitch partner. Which is harder, by the way. Twitch partner is hard. It is harder. I am having trouble getting Twitch partner. Affiliate is easier, but Twitch partner it's hard for me. That's kind of like going in full-time na ate. Ooh. What, Twitch partner? I can't do full-time streaming because of my job. I'm a doctor. That one comes first. But I am, like I said, like in the beginning of the year, I am trying to part-time this. So that's why That is why I am able to at least vomit out some shorts or whatever videos. Like, I think I am producing more videos now than I did last year. Even if it's just shorts, man. It's just shorts. Like shorts or reels. And most of my reels are shorts and reels are Tekken related because I play Tekken a lot. But, you know, it works for me. Going multi-platform? Oh, yeah. I don't know. Some people say it's easier because you just stream and you do it on 2 platforms at the same time. But I don't want to stream at 2 platforms at the same time. I just feel like that's harder to manage. Like, you're gonna look at 2 chats at the same time or multiple chats at the same time. And Twitch doesn't allow multiple chats at the same time. So I'm like, you know, stream 1 platform and another. Do you consider continue Minecraft? Yeah, I might. I suck at Minecraft. You know, I don't really build in Minecraft. I'm not a builder. I'm more of an explorer in Minecraft. I will probably play Minecraft again. Or be exploring. I just explore. I don't really build. I don't know how to build. I don't know how to build anything. I'll just like make a box house and then I'm happy with that. A box house made out of cherry trees and then I'm happy. I should probably do that again. Maybe I can build like a nice house. Nice cherry house. And then, yeah. Kung pwede lang maging 3 kandok kage bunshing times 3. Bruh. Okay, yo, guys. I've been streaming for 2 hours and 22 minutes. It is 11:25. I think we're good. We're good for tonight. I will, post my stream schedule for this week tomorrow. Maybe, let's see, I will do another, wait, we will do a, ano to? Monetization stream sometime this week. I'll probably do an anatomy stream also this week, so that'll be 2 YouTube streams. I'll see. Yeah, we'll see. I have to plan my week. Lots of fun, guys. Thank you for coming to my stream. I hope you guys learned a lot, even though it's a little bit scuffed. Like my PowerPoint wasn't really complete, but I tried to cover as much as I could. I tried. Okay, Shiori, are you a real doctor? Yes, I am a surgeon. So yeah, I hope you guys learned a lot. Buti na lang walang quiz. I'm too tired to give a quiz. Do you want a quiz? Gusto nyo ba ng quiz? Gusto nyo ba? Pwede naman siguro quiz na 30 second quiz. May timer. 30 seconds. May timer. Gawa kayo ng essay tungkol sa esophagus. 30 seconds. Ano? Tulog ka na, ma'am. What was that recent thing that happened? Pag hindi kayo hindi kayo nag-quiz. Ayaw niya mag-quiz, hindi kayo gagraduate, tanggalin nyo yung toga nyo. Tanggalin yung toga nyo, dapat naka-uniform. Do you guys know that? I saw this on Facebook. Oh God. Oh my God. Tanggalin nyo yung toga nyo. Angal kayo? Angal pa? Bonjing. Principal, wag mo. Actually, you know that incident, I don't know the context. I mean, I don't know why she did what she did, basically. I was like wondering, why? But I don't know why she did what she did. But it's just that the way she did things, it doesn't look good no matter what reason it was. I can't think of a reason that would be legitimate or that would make her right in doing what she did. Unless the students were the first ones to do something bad outright during the ceremony, then yeah, I would understand that. But I saw the entire video and she just started talking. and then some kid randomly just shouted. Di ata sinunod ng magulang yung uniform for graduation? Isn't there supposed to be a meeting for that? There's either a meeting or like a memo for it. She needs to comply to a rule, but apparently Depa said he can wear toga. Nadamay tuloy yung mga matitino sa graduation. Yeah, that's the thing. I don't know the entire context. So the video just showed her getting up on the stage and then reprimanding the students without being triggered to. Because if that one kid that shouted a curse at the principal happened first and then she started saying stuff like that, then I would understand. But it happened the other way around. She started talking and saying stuff before the kid lost it. So, I don't know really the context. I was trying to think what happened. What is it that happened that made her do that? Because why would you do that? I'm trying to understand. Di naman prohibited pagsuot ng toga, but preferably naka-school uniform lahat. Okay. If the principal wanted them to wear the school uniform and not toga, wasn't there a meeting for that? And a memo? Like a memo saying, okay, the uniform for the ceremony is this. Because if there was a memo for that, and there was a meeting and it was agreed upon that they're gonna wear a uniform, then why didn't they wear uniform? Why did the students not wear uniform? Because if it was agreed upon that this is what they're gonna wear, then why did they not follow it? There was a meeting and around 100 parents agreed. Parents agreed with the togas. Okay. So the parents agreed. Was it agreed to the whole body? Like, if it's like you discuss something and you say, okay, let's wear the toga, let's go toga. Was the principal in that meeting? Or was the principal informed about what the dress code was supposed to be? Because the way she walked up there, she's like, wasn't it supposed to be uniform, blah blah blah, and not toga, yada yada yada. It's as if she didn't know what was going on. Baka di lang ata na spread. Yeah, that's what I'm thinking. Because if majority of the people agreed to the toga and the principal didn't know about it, that is odd. Why did she not know about it? Was it that wasn't like, I mean, even if there was a meeting, there should be like a memo. Isn't there supposed to be like a memo? Money is also involved in speaking of toga. In our school, the school calls for a PTA meeting. That's where they decide what to wear. And only grades that have moving up is the one that needs to wear toga. But only Peach and Weaver you need. Okay. For graduation. Okay. Yeah, that's the thing. They're supposed to be meeting and they make an agreement. And if majority agreed, and the principal knows that majority prefers the toga, yeah, you know, I don't... Baka di makagraduate yan ako, principal. Grabe naman! Kaya pala, eh, no? Kaya pala, di makagraduate yung anak ng principal. No, I just want to understand. I just want to understand. I don't want to judge everything based on, you know, because even though that video was like around, was like spreading all over the place, like, you know, that video, that incident came up on my feed like 5 times in the same day. And I was like, isn't there more to this? Like, I need to know why is this happening? My previous issue ata yung principal, kaya play safe siya dun sa di nag-agree sa toga. Parang abuse of power lang talaga nangyari. Yeah, if it's like, okay, in the meeting they say, okay, toga. Pero sabi ng principal, no, I want uniform. But even so, if you had that meeting, majority wants toga, but the principal puts her foot down and says, no, it has to be this. And then it was official that it has to be this. And then they just end up wearing toga anyway, then isn't that also not following? I don't know. I don't know. Was she like that in the PTA, you know? Like, oh no, I want this. Which is actually, I don't think she should be like that. She shouldn't be like that though, but I mean, if you have a meeting like that, you have to have a discussion. Like, why do the parents want the toga more? I think it's because it's cheaper, right? I mean, that should have come up in the meeting. Like, it's cheaper, it's more, you save more money this way. I mean, normally, I would think a principal that was a person ahead that was in that meeting would understand that, yeah, oh yeah, it is cheaper. Sige, toga na lang. But I don't know why she insisted in the uniform. If the toga is cheaper, and that's what majority wants, she should have just followed what majority wants, because, you know, it's cheaper. What's the motive of the principal? I don't know. Good night, Doc. Okay, Denison, good night. Good night. Anyway, yeah, that's I don't know. Either way, I don't think the principal should have done what she did, no matter what it was. Let's say it was a mistake. Let's say it was, oh, but we thought togas are okay, and majority wore the toga. You know, despite the meeting, they agreed in the meeting that it would be this uniform, but oh, we decided toga, and majority of people are wearing the toga already. Like, yeah, you can be disappointed, but don't do it on stage. Like, you can deal with that after. That's what I mean. Like, I don't think she should have did what she did. Yeah, it was unprofessional. Yeah, it was. It was unprofessional. Like, no matter what the reason was. Well, except, like I said, if it's bad thing that happened during the graduation where the students were being assholes right there and then yeah, I would understand. But this one is different. She just walked up on the stage and started reprimanding people. So, yeah, you know, that's unprofessional. Hulak ko lang is nagugulan siya dahil may students na naka-uni and Some students are not nakatoga. Siguro nga. I think so. Yeah, maybe. I don't know. I will never know. We may never know unless she starts talking. Yeah, and it was unprofessional. It was like she could have dealt with that after. Like let them go through the graduation rites because it's their graduation. Just let them go through it. Then you can reprimand them after, but not during. Like do something about it after. Talk to them after, not during. My gosh. Yeah, just push through with the graduation as it is. Don't make them remove their toga, don't make a scene. And then deal with the problem later. Because, you know, it's a graduation. Okay. Anyway, oh my god, guys. It's 11:39. I'm supposed to end stream a while ago. The only thing that pissed me off was holding up their diplomas and Nana. Yeah, that one was terrible, man. That was terrible. I don't think that should have been done. Especially with an issue like that. Where they just wore a different dress code. Okay. Anyway, yeah, guys, time to go to bed. Time to go to bed, guys. I will post my stream schedule tomorrow. Maybe, yeah, tomorrow I will plan my week. And I'll think of what I'm gonna do for the YouTube monetization stream. I will think of a pakulo. What else? Happy Easter, guys. It is Easter Sunday tomorrow. So I'm just gonna greet you now. 20 minutes before 12 midnight. Happy Easter. I hope you guys catch the Easter bunny. Alright, guys. Good night. Lots of fun, guys. Thank you for coming to my stream and for listening in. I hope you guys learned a lot from the esophagus and the stomach. And I know we just ended up yapping about random things afterwards. Yeah, good night. Good night, guys. Bye-bye, Otsu. I'll see you guys again soon. Bye-bye, Otsu.